Well, thank you. I am thrilled to have the opportunity to participate in this meeting. And what I'm going to talk about today is related to, in particular, the ACC Clinical Registries, and focus a bit on heart failure management. So the ACC developed the NCDR registries almost 20 years ago, and their mission is improving quality of cardiovascular patient care by providing information, knowledge, and tools, implementing quality initiatives, and supporting research to improve patient care and outcomes. And the registries support our strategic plan, and in particular around data information and knowledge, population health, and transformation of care. And we'll talk a little bit about that as we move along. And at the core of the ACC strategy, as it relates to the NCDR registry, is to identify unique clinical information that will enable physicians to understand their performance measurement, also support research, and deliver quality improvement programs. So there are multiple registries within the NCDR, and for today I'm going to focus particularly on the PINNACLE Registry, which began just about 10 years ago. But as you can see, we started with the CAP PCR registry almost 20 years ago. And so with the registries allow us to have continuous clinical data through the registry, and to combine that with administrative and other data to create an analytic database, and use that, as I said, to focus on quality improvement, clinical research in particular, and then ultimately improves healthcare quality for patients. The NCDR does collaborate with other societies around the country and internationally as well. And they collaborate also as they focus on devices and the development or the understanding of how devices are working both in the U.S. and abroad. I just wanted to focus on a couple of points as it relates to the NCDR strategy. And one is to ensure registry data are high quality. Again, any registry is only as good as the data that is imported into the registry, and so it's important that the data be complete, consistent, and accurate. And along the same lines, we continue to focus on how to decrease the burden of data collection, because that certainly impacts the ability to collect complete data. Dr. Wall showed this slide earlier, and I will focus a bit on PINNACLE, which is the largest outpatient CT registry in the U.S., over 50 million records from 12 million unique patient lives. And the PINNACLE outpatient registry tracks 4 clinical conditions: patients with coronary artery disease, heart failure, atrial fibrillation, and hypertension. And it's focused on measuring adherence to clinical guidelines, eliminating and reducing variations in care, improve care coordination for cardiovascular patients, and facilitate overall improvement in outpatient care. And again, the way PINNACLE and the other registries takes information from electronic health records, other data sources, integrates that, and creates a clinical data repository in which to extract information from the registry. And in the United States, we have multiple electronic health records, and one of the unique advantages of our registry is the ability to take information from any of these electronic health records. As I mentioned, PINNACLE data looks at not only demographics, it looks at diabetes, cardiovascular disease, other comorbid conditions, whether patients have cardiovascular events. It includes lab values and medications. So if you look at the PINNACLE registry by disease state, you can see that the highest number of records are for patients with hypertension and diabetes. There's almost 2 million patient encounters for those with heart failure. And again, as Dr. Walsh mentioned, these conditions don't occur in isolation. So if you're focused on your patients in heart failure, many of them will have hypertension, diabetes, and coronary artery disease, and it'll be important to monitor the compliance around medications and for those clinical conditions as well. And the way that data is developed, a work group is identified, they develop data set of which there's a comment period, and then scientific leadership at ACC approves those and then hand it off to the registry for implementation. So amongst the heart failure data elements in PINNACLE, there's assessment of ejection fraction, symptom and activity assessment, symptom management, patient self-care education, counseling for ICD implantation for those with low ejection fraction, fields for etiology of heart failure, and then use of medications including beta blocker, ACE or ARB for diabetes or low ejection fraction. They also collect information on sodium and potassium levels as well as natriuretic peptide biomarker assessment. Finally, they also include they've added the ARNI therapy and as well as hydralazine and isosorphide dinitrate therapy for African Americans. But as I mentioned, it's not in isolation. So we're also on the same patient who has coronary disease and heart failure. We're also collecting data on their blood pressure control, lipids, therapies, and their platelet therapy, their symptom and activity assessment, smoking cessation, which again Dr. Walsh mentioned earlier is such an important part of managing heart failure patients, as well as whether the patient was referred for cardiac rehab. And again, patients also have heart failure have atrial fibrillation, so the PINNACLE Data Registry is able to collect data on their risk assessment for thromboembolic events, and then their chronic anticoagulation management. And finally, for those with advanced heart failure, if indeed there's advanced care planning. So this is an example of the PINNACLE Registry. This was our most recent Q2 2017 national summary data. And so the measures are listed in the first column. So just as an example, for symptom management, if symptoms improve, you can see that overall the reporting was actually quite high, and over 80% certainly for all the patients. But then in some of the other measures, such as patient self-care management, you can see that there's a wide distribution in whether that performance measure was completed, and certainly an opportunity for improvement. Beta blocker therapy, which generally has high performance, and again, that's seen here in our most recent data. That's the same for ACE or ARB therapy. If you look at counseling for ICD implementation, again, overall, there's opportunity for improvement as the performance rates are generally low, as is the data around etiology of diagnosis of heart failure actually being inputted into the PINNACLE Registry. And then for ACE and ARB, or ARNI therapy, again, high performance, although for ARNI therapy, in particular, for class 2 or 3 heart failure, overall documentation of that was low. So that's at the high level, and then at the advantage of the registry is that we can then provide the physicians a scorecard. Now this is for the PCI registry as an example, but you can provide to the patient, in this example, a volume summary. So if someone is doing PCI, it tells them how many procedures they performed, and it compares them to others around the country also performing procedures. So one of the strengths of these registries is the ability to provide the physicians their own performance data and where there's opportunities for improvement. So I'll turn to a few studies that have been reported out of the registry as it relates to heart failure. One was looking at practices. So is there variation amongst practices in the use of recommended medications? This looked at around 12,000 patients in 45 practices. And when you look at the results, I know this is a busy slide, but in terms of prescription rates associated with patient characteristics, there really wasn't much difference whether looking at ACE/ARB, beta blocker, or the composite, except in one area, which was for those who had undergone a recent PCI, where the prescription rates in general were higher for those undergoing that procedure. But despite that, you can see that this is just looking at variation amongst practices, looking at the composite prescription rate. You can see wide variation. So one of the strengths of this type of registry is for physicians to look at their own information and see how they compare to others. There's another study that looked at provider and practice volume as a predictor of adherence to these measures. This looked at almost 30,000 heart failure patients. And there was a wide variation in volume both by patient practice characteristics and provider characteristics. But again, there really wasn't much difference except for provider volume in terms of high volume heart failure physicians tended to do better in terms of beta blocker therapy prescriptions. And it's not just the PINNACLE Registry. Looking at other registries in NCDR, you can look at the ACTION Registry to look at acute myocardial infarction patients with cardiogenic shock. This was in over 112,000 patients, 5% had cardiogenic shock, looking at all-cause mortality. And here in the ACTION Registry study, you can look at overall clinical events. And obviously, you can see that those with shock have a higher incidence. But one of the takeaways from this study was, not surprisingly, the difference was quite significant early, but after 60 days, the difference in terms of overall death was not statistically significant. And if you combine all-cause hospitalizations with death, you can see that after 60 days, they tended to be very similar. Again, as Dr. Walsh mentioned, PINNACLE has moved beyond the U.S. So this is a study out of India, which has a growing registry as relates to PINNACLE outpatients. And then Brazil has also started entering patients into the PINNACLE registry. And they have developed a web system that mirrors the ACC case report. They have about 5,000 patients enrolled. 500 physicians are enrolling patients. And again, not only heart failure, but they're including data on their patients with hypertension, diabetes, coronary artery disease. And they're also looking at the PINNACLE performance measures. So in heart failure, 144 is beta blocker therapy, and their rates are relatively low. So they see that as a significant opportunity for improvement. And so how are they trying to increase PINNACLE participation? They're educating and recruiting amongst the cardiology educational opportunities. They also have sort of a competition amongst the physicians in Brazil for participating in PINNACLE, and then of course they're supporting students and fellows to improve enrollment. And finally, I just want to mention that we've already talked about registries in China. This was a recent study published in August. There was a multi-center registry study here in Beijing looking at heart failure management outcomes in patients presented to the emergency room. And it looked at approximately 3,300 acute heart failure patients presented to 14 emergency rooms in Beijing, large hospitals, and they looked at 30-day and 1-year all-cause mortality and readmissions. And some of the patients died while in the emergency room. Obviously, there was a number who died within 30 days and then out at 1 year, but approximately 1,900 patients survived out to 1 year. And one of the interesting things I noted in this emergency room disposition is that only 55% of the patients are admitted, and that would be quite different than in the United States, where those who present with acute heart failure, invariably they would be admitted to the hospital. So I think we have something to learn from here in China, where we've figured out a way to manage a significant number of these patients who present to emergency room with acute heart failure. We're able to send them home 34%, and then manage them as an outpatient. And then when you look at 30-day and 1-year mortality, again, there really wasn't, these are pretty consistent with findings that we see in in the U.S. And then finally, when they look at medication utilization here amongst those patients, again, you see opportunities where use of ACE and ARB and beta blocker, as well as spironolactone, for this particular patient population who presented to emergency room, they gained an opportunity to improve those adherence rates. So just to finish up, NCDR started in 1997 with the PCI Registry and has grown significantly over those 20 years. And as I mentioned, now expanding with multiple international collaborations. It's a platform for not only clinical trials, but for other opportunities. And finally, I would say that science tells us what we can do, guidelines what we should do, but registries, what we are actually doing. Thank you.